Good afternoon, and welcome to the 10 Keys to Unlocking Revenue Potential: How Medical Device Companies Can Increase Revenue Through Relationships. My name is Steve Selbst, and I'm the CEO and co owner of HealthSense Inc. And I'm joined today by Ms. Regina Vasquez, our VP of Accounts, and we're delighted to have the opportunity to share some very useful and practical tips about how to increase revenues, whether you're a medical device manufacturer, a distributor, or both, or for that matter, a DME or O&P company. All of these tips will come in handy relative to finding new ways to increase revenues. Before we begin the content part of the session, I would like to offer you an opportunity two different ways today during the next hour to ask questions at any time, beginning right now. You can send an email to info@healthsense.com, exactly as specified here on the screen, and we will pick up your questions real time. Regina will be emceeing the question and answer sessions. We will pause at least once or twice during the session and at the end to field any questions that you might have, and we encourage participation as we find that the more interactive these sessions are, the more value is derived by the participants. So feel free to send your questions to info@healthsense.com. Also, during breaks, you may pause to ask your question by simply pressing *6 on your phone line. That will open up the phone line to enable you to ask a question, and after you're done asking your question and conversing with Regina and I as we dialogue with you and answering the question, then please once again press *6 on your phone to close out the phone line so we don't hear any background noise. And this way we can leave the session in a question and answer mode, and I'll remind you that you can go ahead and ask any live questions by pressing *6, or beginning now, you may send any questions to info@healthsense.com. Also, this session is being broadcast live, so you may join at any point in time by simply, in any browser, going to join.me/healthsense. So for any reason you lose contact with us during this webinar, it's very easy to get back. You just go ahead and type join.me/healthsense, and you'll be returned into the session. A common question that we get on the front end is, how do I get copies of the session, the charts, as well as the recording? And the answer to that is, following the session, you can go to healthsense.com/copy and fill out the short form there, and you'll immediately be returned a PDF copy of the charts. Right now we have a recording of a prior webinar on this topic there as well. Within the next 24 hours, we will post the actual recording of this session at that location. So again, to get copies, go to healthsense.com/copy in your favorite web browser, and you'll be able to get copies in that way as soon as the session is over. Now, a couple of introductory comments about HealthSense Inc., just so you know who we are for those that haven't worked with us in the past. We are a nationwide corporation founded in 1994. We have a number of different services that we offer to medical device manufacturers, DME companies, and really providers at large. We have many different sizes and types of physician practices, specialty hospitals, large hospital group-based practices, ASCs, ancillary providers of all types. We pretty much span the spectrum of enabling all kinds of medical providers, and today's focus is on you, medical device manufacturers, DME, O&P companies, about enabling new revenue streams, and in particular maximizing revenue and profitability through vehicles such as payer contracts, formularies, GPOs, buy and bill techniques, etc., which we'll be talking about today. We also do a variety of general healthcare consulting for retail organizations, including doing regulation updates, regular webinars on a variety of different healthcare topics, et cetera, and have done research at the very beginning and right through the rollout of the Affordable Care Act. So we have quite a bit of knowledge in that domain as well. We offer a class. In fact, we have a session that begins tomorrow called the Blueprint for Success. It's a four-part payer contracting class that is taught basically in a manner where we can convey all of the tools and techniques that we use when you outsource payer contracting, negotiation analysis to our company. We also have a software product. It's called Revolution Software. It's a cloud-based, internet-based service that is designed to provide a variety of different reports and business models all around the theme of how to increase and maximize reimbursements on payer contracts. We literally have 300 active clients currently. Many thousands have been served through our business. And you can read more about us in our testimonials at healthsense.com and go to the testimonials page. Our leadership today, I'm talking with you. I'm Steve, and I manage our entire business, including our operations and contract negotiations. I always like to say that I have my IBM degree, while my colleague and partner, Ms. Susan Charkin, has her MPH degrees, and we've both been in this business now for, I've been in it for about 13 plus years, and she's been in it about 10 years longer than me, and has a pedigree of doing a variety of payer contracting positions and opportunities, including working for various blues organizations, being the director of outpatient surgery at UCSF, trustee at a large hospital in the area, et cetera. And Regina Vasquez, who's our senior VP of accounts, she really has her pulse on our day-to-day business, as she literally leads our contracting and consulting activities with our clients each and every day, all sizes and shapes of providers. She knows medical device manufacturers, DMEs, O&P companies, medical device distributors extremely well. One of our large and referenceable accounts that Regina works on is Alere Incorporated, a large publicly held company, and she is very well equipped to handle our Q&A today. So what can we do to help you? Well, the first thing we want to do today is provide you basically some free information that you can take back with you. And I believe if you listen carefully to this webinar and take the advice back out of this webinar, you will in fact be able to implement some of the techniques and build them out yourselves. We can also be an outsourced vehicle for you and actually handle direct negotiations, not only with payers, but also enable the appropriate processes to get you into GPOs and formularies and PBMs, depending on what the best fit is, and also give you some really useful techniques, and we'll start to unveil some of that today relative to the buy and bill process in terms of how you can get your physicians enrolled when you're selling them products, so that you can give them the tips and techniques that they need to get reimbursed appropriately on the services that correspond to the use of your medical device and O&P products. We also do quite a bit in the way of claims troubleshooting, claims analysis, and tracking. Often when you get into agreements with payers, a lot of times, unfortunately, medical device companies and providers at large don't have the appropriate tracking mechanisms in place to make sure that claims, in fact, are being paid per contracted rates, and money can often be left on the table. So we'll give you some advice today about how to ensure that your claims are tracked correctly. And I mentioned that we have various training classes like the Blueprint for Success class, and like these shorter webinar series that we offer up as a value add to current and prospective clients. Our focus is on results, as I know yours is, in terms of patient satisfaction, but in terms of making sure that your practices and companies are indeed profitable. And bottom line is we have both the business processes and the cloud-based tools to ensure that success. Now, getting to the topic at hand, the reason we're together today is to provide you with some successful techniques and strategies that can actually enable new revenue streams. And I find that having worked now with literally hundreds of medical device manufacturers and DME companies over the years, and currently, that we all share one thing in common. We're either selling ultimately to um, practices or providers, or we're selling to patients. And many times I find that the sales channels selected are very limited. Maybe you're just selling to a medical practice, and that's basically the extent of the sales opportunity. Everything is geared at messages about selling products to physicians, for example. But there can be a lot more to that, like how can we make sure that the physician ultimately gets billed, is billing out properly for their services so that they can get reimbursed and really achieve not only clinical outcomes from the use of your products, but also better returns on investment. And that's what we're going to focus on. Similarly, when you go to market selling to patients, we see a lot of scenarios where it's just a direct sale to the general public, and there could be other ways of broadening the opportunity base, whether that's through PBMs or formularies, the appropriate distribution agreements, and GPOs. So we're going to kind of lay out some of these different mechanisms. We're going to define them. We're going to talk about how they can help you to generate potentially new revenue streams. And I will tell you up front that the correct mix of, should you be in a PBM and a formulary, or should you have a retail distribution agreement, a GPO, should you do a buy and bill directly to a practice, all of these kinds of questions need to be answered very specifically and very precisely for your company. So my goal today is to lay out the different mechanisms and what they are and where they might fit. But as far as really tailoring it to your needs, I would suggest to you that you take advantage of what's going to be my offer to you at the end, and that's going to be for a half-hour consultation, no cost or obligation, where we can really drill into and talk about your specific needs. But today we can certainly open up the aperture and give you the different mechanisms, relationships that can help you broaden your revenue base and therefore your revenue stream. The goal ultimately as well is to learn how to successfully negotiate with these organizations so that you can get the most profitable agreements in place. So let's talk about sources of revenue. Now, the traditional source, the buy and bill, is where we see a lot of medical device manufacturers and distributors selling products. That is direct sale to practices, and then the practice in turn bills out. That's where the term buy and bill comes from. They bill out typically to a health insurance company and or to a patient. The fees for your product, largely, if they're in a payer agreement, it's going to be in concert with the CPT codes that they can get reimbursed on. Or perhaps if it's an ASC, it might be through an implant type of a reimbursement. But basically, the direct sale to the practice tends to be one of the more common. Less common, but very critical, are commercial health insurance companies. And if you're selling to patients, certainly getting into agreements with health insurance companies or payers is a terrific source of revenue. Pharmacy benefit managers, your CVSs, your Express Scripts, those kinds of organizations can be very appropriate depending on the nature of your device and the way that you distribute it. Formularies are quite critical to medical device manufacturers because you get on the list of the formulary. That's basically putting you in a scenario where you can be a part of a recommended list of products and drugs that are ultimately sold by the pharmacy benefit manager. And then GPOs, group purchase organizations. This can be a huge opportunity and channel, and I'm going to show you a diagram of exactly how the GPO works. But basically the idea is that the GPO has members that are provider organizations, and those members typically pay a fee to belong to the GPO, and in return there can be literally hundreds or even thousands of device companies that are enrolled, um, and different medical supply companies to sell products through the GPO at a discount for the members. And members range from smaller practices to huge integrated hospital systems. So you can open up quite a bit of opportunity if you understand what GPOs are and basically get enrolled with some of the large GPOs. And then we'll talk about distributors. If you have sold traditionally to medical practices, nowadays there are companies like Quill Healthcare, Guess and Henry Schein. Those kinds of organizations are companies that largely now are selling into verticals as well, selling directly into medical practices. So it would be a good idea to look at the retail distribution network as another mechanism in addition to the buy and bill process that you may have used traditionally. So the goal today is to kind of lay down the foundation for these different sources of revenue and get you thinking about how you can expand the opportunity to increase revenue in your company by leveraging the right mix of these organizations to fit your needs. And as with any mechanism, it's important to make sure we all have a clear understanding of what that mechanism is and how to then go about getting contracted with that particular channel of or revenue source. In terms of payers, what are payers? Payers are health insurance companies, basically companies like Blue Cross, Blue Shield across the different states, United Healthcare, Cigna, Aetna, HealthNet, et cetera, just to name a few of the large ones that we're probably all familiar with. And the agreements with these payers, we're talking about now commercial payers, there are also Medicare Advantage programs that many of these payers carry as well. But the idea with payers is that you can have a direct contract with the payer, and then when they in turn sell to their beneficiaries or insured patients, then in turn you get reimbursed from the payer for the bulk of the cost of your medical device or equipment. So there are two flavors. Fundamentally, there's the direct agreement with the health insurance carrier, and then there are large organizations like the one that I used to work for, IBM, where they are self-insured employer groups, but they essentially hire a third-party organization. In the case of IBM, they use Empire Blue in New York as their insurance arm, but basically they're doing a self-insurance scenario and paying Empire Blue to administer. So you see that with many large employer groups is they essentially self-insure and hire a third large well-known insurance company to implement their programs. So payers, health insurance companies, and self-insured employer groups are one such opportunity. The second one is the pharmacy benefit manager, also known as PBMs. Here we have some familiar names, CVS Caremark, Medco, Express Scripts, to name a few. And basically this is a company that manages the pharmacy benefit program for an insurer, for an employer, or a health insurance company or health plan. And the way that this works is, you might be enrolled in a plan, for instance, through IBM, if you're an IBM employee, but you also have a pharmacy benefit, and the pharmacy benefit company like a CVS Caremark, for example, might be the company that is essentially providing the pharmacy benefit support as part of the insurance plan for the large employer. So the PBM is very critical because PBM, depending on the device that you have, is not only a great vehicle for prescription drugs, but it is also a terrific vehicle for certain kinds of medical device and distribution scenarios. The idea of the pharmacy benefit managers, in effect, they pay and process all of the pharmacy claims that are part of the broader health insurance plan, and also manage and maintain formularies. So what are formularies? Well, formularies are basically lists of specific drugs or products, can be medical devices, O&P equipment, that will be reimbursed by the payers through the PBM. And formularies come in a couple of different flavors. One is the category of formulary and the type or gradient. So let's talk about the category. Well, we have open formularies. These are less restrictive kinds of formularies that might list many or all of the drugs or products that are a part of the formulary, and there may be rankings based on the preferred status within an open formulary. On the other end, the more restrictive closed formularies, and this is where there's a limited list of approved drugs that are actually covered by the plan. And even though it's closed formulary, in that scenario, it may allow for patient access to non-formulary based products, but with much higher copays. And then in the middle, you have these managed formularies, which take on the characteristic of an open formulary, but provide typically an incentive that will encourage the use of the preferred products that are a part of the formulary. So formularies have different gradients. The key is, to get hooked up with formularies. If ultimately the PBM is a good mechanism to go to market, you'll want to be on a formulary list, particularly as a device manufacturer. Then the tiers of these formularies, we have generic kinds of products or drugs are typically at the lowest tier, and then brand names at the highest. And the higher up you go in the chain here, brand name is going to require higher co-payment than would a generic, and then in between you might have a brand name that has some unique clinical value, which is how it got into formulary tier 2. So you have the different types and you have different tiers of formularies. Before I move on to group purchase organizations, let me pause for a moment. This is probably a good break point. We're almost, believe it or not, almost halfway through the session. And ask Regina, first off, if we have any questions that might have come in through info@healthsense.com. Regina?
I have actually two questions here, and they both have to do with self-insured groups. The first question is, do self-insured employers, you mentioned that some of them use third-party organizations like insurance companies to administer their benefits. If you want to get a contract with an employer group, do you contact the payer or the employer group?
Good question. Well, first off, typically the employer groups, first off, are serving the beneficiaries are their employees typically. So in terms of how you get contracted with an employer group, you can actually go about it a couple of different ways. You can go about doing an outreach through the HR department at the employer group and figure out who the employer is using to insure its employees and make the case for why it's a good thing for their employees to have access to your products in terms of patient care and benefits. So kind of get the employer rallied on your side. And then you go back and work on a contract directly with the health insurance company who is typically administering the employer group contract. So you would need to reach out ultimately to the health insurance company from a contractual mechanism perspective, but I think it's certainly important to build relationships with large employer groups who are using these third-party health insurance companies to administer their plans so that they see the benefits of your products and become an advocate for getting you in the employer's network. Did you want to add to that as well, Regina?
No, you've encapsulated exactly what I would have said, and that actually answers the second question, too, as part of your explanation, which is, can a provider make any headway by going through the employer group? And I believe the answer to that, we both agree, is yes, that they can gain advocacy through the employer group to have a provider admitted to a network.
Yeah, absolutely. Excellent.
Yeah.
Let me as well open up the phone lines. Again, to remind the participants, if you would like to ask a live question at this time, what you would need to do, let me first unlock the lines and then I'll tell you what you would need to do. Okay, so if you would like to ask a live question, please simply press *6 at this time on your phone and go ahead and ask your question. Any live questions outside of info at HealthSense? Okay. Well, we will pause at least one other time to take questions, and I'll remind you again, if you'd like to ask a live question at that point, just press *6 on your phone and please jump right in and ask your question. Now, the next topic or next revenue stream or source is called the Group Purchasing Organization, also known as GPOs. And what are some examples of GPOs? Well, there are many large GPOs that literally have thousands of members. I've listed a few of the larger names, but you could easily bite off and chew a list of 10 to 20, and you would each one potentially would connect you into thousands of providers. So this is a vast network. I always recommend a practical approach. Make sure that the description of the GPO is such. There are some that are very specialized, for example, that sell OBGYN equipment, and that's really what their specialty is. But many of them are broad. Premier, Med Assets, Amerinet Innovation, these kinds of organizations, basically sell across a variety of different specialties, and therefore would be appropriate for a wide range of different medical supply products. These are organizations that are there to leverage the purchasing power of its members, which are providers, and the goal is to get these members preferred pricing. If you will, it's not unlike a Costco model, except the difference is Costco stocks products. The GPO doesn't stock products, but they do offer the discounts. And the idea is that there are contracts between the GPO and each of the vendors to offer their products at steep discounts, many going 15 to 40% or so in terms of the discount range. So the play here is to come down off retail prices, provide discounts, but open up a very high volume of opportunity of selling products to the GPO membership. The funding of the GPO is primarily through membership fees, but some of the GPOs also require about a 3% administrative fee on behalf of the vendors, depending on the terms and conditions of the GPO. And as I mentioned, they're like Costco, except they don't have a storefront where they stock products. They just offer contracts with the direct suppliers of products, the vendors, yourselves, or distributors, and they create these contracts so that the membership can obtain the discounts. This is what the GPO model looks like. A picture probably worth 1,000 words in the case of the GPO. So on the left, you have the healthcare providers. Now, there are some that are ownership-based models where they might actually get retained earnings distributed back to them in the form of dividends and some quarterly or annual basis. The important thing for you to know is that you have providers that are the members or owners, and they pay their membership dues to the GPO. The GPO then negotiates these agreements here with the vendors, which can be manufacturers or distributors. So either it certainly could be appropriate for O&P, PME, any kind of medical device scenario is very appropriate here. And in turn, discounts are offered back to the membership. So that's the model. The GPO is the contracting mechanism that puts contracts in place with the vendors to offer up products back to the providers. And why is this beneficial for you to know? Because you can build an enormous sales channel potentially by getting enrolled in the proper GPO agreements. The reach of these is absolutely enormous. You'll see, some of these have, well over 10,000 providers, including, major hospital systems and hospital group based medical organizations. They're extremely large with lots of tentacles, and that means lots of revenue opportunity, a new sales channel. That's the context. Then we talk about distributors. Now, distributors basically are companies like Quill Healthcare, McKesson, Henry Schein, that in turn, in the case of the healthcare space, are reselling medical supplies, medical devices, depending on customer need. And often these companies are not only selling to consumers. We might see these companies selling office supply products and those types of things as well, but they're also selling into the healthcare vertical space, namely to medical providers of all types. So getting the appropriate distribution, retail distribution agreements in place, in addition to whatever buy and bill agreements you may have already put in place or thinking about putting in place with practices, would open up yet another sales channel. So, think about the retail distribution network as yet another source of revenue. So if we look at the map here and kind of put this together in a single chart, what we have on the left are your products. And the traditional channel, let's say the buy and bill, where you might sell into providers, then would determine the fact that you need to really help the providers with mechanisms of how they're going to use your product and ultimately make money back through their billing of services. And we'll talk about that in a moment. But we've introduced here some new opportunities, direct agreements with commercial payers and as well as self-insured payers. And Regina asked us you asked Regina a couple of excellent questions about how that mechanism works. Then we talked about PBMs and formularies, formulary being the list and the PBM being the pharmacy benefit manager, and why these vehicles are excellent ways of ultimately getting your products out to patients who need your products. And then the GPO or distributor agreement, yet another excellent vehicle for providers. And as I say, the idea here is to expand your channel reach and get the right mix of these channels in place, in addition to whatever your traditional selling might dictate, whether it's a direct sales model or another kind of model, so that you can open up revenue opportunity. Now, I'm going to go into a little bit of the characteristics of buy and bill scenarios. And again, what is a buy and bill? It means that you're selling your product to a medical practice, and the medical practice in turn is going to bill for its services, and ultimately that's going to be the mechanism where the medical practice can achieve ROI, or return on investment, by deploying your products in their practice. So the key here is to identify the codes, the CPT codes that are billed by your client, the practice, and make sure that you understand what the various commercial payers and Medicare Advantage payers are doing relative to the reimbursement of the CPT codes and or implants, depending on the scenario, that might be carried by might carry your product. So you want to be able to, as part of the technique of selling directly into a practice, you want to be able to teach that practice how to go about obtaining reimbursement for the codes that they're billing against, because that's going to make it much more consumable and not just look like it's a capital investment in terms of buying your product, but rather there's a way to recoup the investment as well as enhancing patient care by using your products. The idea would then be to assist your practice in doing what we often do with practices, and that's building an overall contracting strategy for your practice to raise their reimbursement rates overall, and for the codes that carry your products and services, so that you can add value to the practice and essentially penetrate a much larger number of practices with your products and enhance patient care. And you develop a great three-legged stool that way, where the patient benefits with better care, the practice benefits ultimately by making more money, and the the payers actually benefit too, because now they're providing a better care by having your products in the network. And then the fourth leg is you, and you make more money. And that's what we want to see happen with the buy and bill scenario. So we have a direct payer contracting strategy, and we're going to share with you a little bit about how you go about doing that. What you want to do is map your strategy state by state and across the country. Some payers offer reimbursement plans that are national by nature. Therefore, you only need one contract, and it's going to govern reimbursement across the states. More commonly, each state or each payer is going to have a separate agreement, or sometimes agreements might extend to regional, where it might be a southeast agreement covering a few different states, that sort of thing. But by and large, you need to kind of do this mapping of your sales strategy to your payer contracting strategy, because you want the two dovetail together. If you're not out there selling on the West Coast, but you are selling on the East Coast, and that's where your sales force is currently located, then you're probably going to want to start by mapping your contracting strategy to the areas where you currently have sales coverage and where you're expanding that sales coverage. We've had a number of clients actually where worked with them over a period of years actually to chip away at building a map of payer contracts. That we have some that are still on board, in fact, doing this, where they have very deliberately built out a sales strategy, a key part of which was getting these payer contracts in place in the appropriate regions in support of that strategy. And the other thing is, a lot of products carry a services component, and sometimes those services components are actually billed as separate CPT codes, or in the worst case, might even have a catch-all code for services. Sure that you're getting the maximum reimbursement benefit ultimately for your products, where not only the CPT codes are billed, but the appropriate services are billed. And you also have to consider whether you're providing this advice just through a buy and bill scenario, or if it's advantageous for you to deploy this kind of a payer contracting strategy yourselves directly with commercial payers, so that you can build the payer relationships to have patients directly consume your products. And this is where you get back to, who are you selling to? Are you selling to patients directly? Are you selling to providers directly? Are you selling to both? Because that's also going to determine whether you're doing a payer contracting strategy in the context of a buy and bill and helping your practices implement this, or whether you're actually doing this yourselves, as some of our clients are, to actually build out direct payer contracts, because they're selling to a broad range of patients across the country in different locations. And then, last but not least, what you want to do with the payer contract scenario is you want to benchmark rates based on available data. Now, sometimes there isn't a lot of data available when it comes to contracted rates, but you may already have access to payer contracted rates, or you may be negotiating several agreements at the same time and getting different offers. And there are very specific techniques that you can deploy where you can actually compare your contracted rates on a normalized volume base and determine the profitability and the viability of these agreements in relation to one another. So what we prescribe here is that best practices for payer contracting boils down to three specific areas, and we're going to dive into these three areas. It's preparing, it's negotiating, and the often forgotten step is monitoring. And I can't tell you how many times we've seen cases where practice goes through the effort to prepare and negotiate an effective contract. The preparing is a lot of upfront analytics, which we'll discuss in a little more detail. They negotiate an agreement, they get a new agreement in place, but then they walk away and just kind of blindly process claims, and ultimately have no idea whether those claims are being paid at contracted rates or below contracted rates. There can be a number of reasons why claims get paid below contracted rates. Some of them you can end up being accountable for and not even realizing it. For example, if the bill charges are lower than the contracted rate, almost every agreement that you would put in place, you would end up getting paid the lesser the bill charge instead of the contracted rate. So making sure that your charge master fundamentally set at a high enough threshold against Medicare rates, usually at about 250%, assuming that they're on the Medicare reimbursement tabula rasa, is about where you'd want it to be. Or maybe that there was an administrative error, the claim wasn't filed correctly, a whole variety of different reasons why this monitoring step can prove to be at least as important as the other major two steps in place here. Now, before I kind of do a deep dive on the techniques around direct payer contracting or buy and bill contracting, I'm going to pause another time here and field questions. And we'll start with info@HealthSense. Go back to Regina and see if any questions have come in at info@HealthSense about this module, either GPOs or payer contracts.
Yeah, we have a few questions on GPOs. The first question is, I'm trying to put it kind of in order that it would make sense. What is the process for getting contracted with a GPO? How does that work?
Okay. Well, interestingly, GPOs publish a specific schedule with dates. It's almost like a project plan of the kinds of products that they're looking to expand and add to the GPO, and they actually set up an RFP or bid process with specific dates. And so the first thing you'd want to do is get hold of that. First, identify if you're not sure which GPOs, well, I've already revealed some of the large ones, and you can easily sort out who some of the other large ones are too. Get that list, and then the next thing you want to do is make sure that the GPO is compatible with your type of device. So, if it's not an OBGYN device, make sure that you, by mistake, didn't end up investigating, an OB kind of GPO. But assuming it's, the right kind of GPO, then you want to get that schedule from the GPO, which they'll provide you. That's publicly available information. And also provide you with links and information that you need to apply. They have very specific processes and dates and so forth that are required in order to participate in the GPO. So bottom line is figure out who the GPOs are, get the schedule, make sure that the kind of device you have that you identified in the schedule, and then get your RFP process going, and really make sure to follow exactly what they're asking for, and you've got an excellent shot of getting into the GPO.
Okay, and that kind of segues into the next question, which is, once you're part of a GPO, can you just sell everything that you offer if you offer more than one item, or is it specific items?
Yeah,
and I think you've answered that.
Yeah, that's right. And yes, correct. As Regina points out, we've answered that because it really is specific to the schedule, the RFP schedule, and acceptance of products by the GPO. So it's not automatic. If you're selling a couple different kinds of heart monitoring devices, that sort of thing, it doesn't mean all of them are going to fit in at the same time. It's going to be based on exactly what the requests are from the particular GPO. But you can easily find a map, most likely within a 6 to 12-month period from any given GPO, where you can likely find a specific plan and approach to getting your products in there. But it's not an automatic where one size fits all, and you're getting your company authorized to sell through the GPO. You're really getting specific products from your company to be authorized to be sold through the GPO.
Okay, and then you mentioned the next question is, you mentioned discounts. Is there a standard discount that a manufacturer could expect?
Yeah, great. These are all great questions that are coming into Regina. No, there isn't, and in fact, there's a bit of a say cat and mouse negotiating game that goes on here because there's a high degree of variability. And, some of what's going to need to take place when you're doing this RFP process is to try to figure out with contacts and by navigating these organizations, kind of what the protocol is for a particular RFP bid, because some of them we've seen in the 40 to 50% range, we've seen others in the 15% range, and typically when you reach out to a GPO, they'll explain what the RFP process is and how to go about making your bid, but they usually won't provide much guidance about exactly what they're looking for, and yet you don't want to overshoot a bid and offer too much of a discount, and you don't want to undershoot it because you're out of range with the other companies that are bidding. So I would say that's where a little bit of the expertise, for instance, that we have might come into play is, you have to be able to get into these organizations, know, kind of who to get to, even if you don't know the people personally, know the people to get to in the organization so that you can put a constructive bid out there to get into the GPO and not provide too good a deal and lose margin, or not provide a good enough deal where they don't want you in the GPO. So that's a great question.
Okay, that's it.
All right, thanks, Regina. And now, once again, I'll open the lines here, at least now and maybe very briefly at the end. If you'd like to ask a question, this would be a great time to do it. Just go ahead and press *6 on your phone if you would, and ask your live question now. Okay. Well, it's not unusual. We find in these webinars that for whatever reason, maybe the duration, folks tend to prefer using the info at HealthSense. So we found that to be a very useful vehicle to get your questions out there and have somebody of Regina's caliber to be able to interpret and field them for you. So we talk about, preparing, negotiating, and monitoring. And then these steps break down further. And this is where you get into the art and science of payer contract negotiations. And this is where, in the prepare stage, we're talking about you do an upfront analysis and benchmark your agreements and figure out, what it is you're going to ask for, put together a proposal letter, which you want to send out to payer. You want to make that initial contact and get the payer on the hook to provide an initial response. So all of that preparation time is going to set the stage for your success in this process. And this is a lot like, we have the, for those that are basketball fans, and even for those that aren't, I think you'll understand this analogy, and that is, we have two teams that are about to face off in the NBA Finals coming up in a couple of days, the Cavaliers and Warriors, and you can bet those teams are spending a huge amount of time, much more than they will actually play in the event, preparing for the event and shooting thousands of shots, doing all kinds of defensive drills, etc. So they probably spend, certainly 60 to 70% of their time getting ready and much less participating in the event. It's that preparation, though, that sets the stage for success. It's very much like that in payer contract negotiations. If you do that upfront analysis and you get these letters right, and you know what to ask for, and you know how to anticipate what a payer is going to come back with, you're going to find the rest of this process of actual negotiations, and if you need to, escalating, is going to go much, much more smoothly. And then we've already talked about the importance of phase 3, which is the monitoring. So the important point I'd like to impress upon here is preparation is very, very critical. And we can teach you great techniques for negotiating, but if you don't know what it is to ask for and why you're asking for it, then you could be the best negotiator in the world and you're not going to do very well. So we want to really ground you in this phase 1. So prepare is evaluation, SWOT analysis, figuring out what your strengths, weaknesses, opportunities, and threats are, and positioning your company appropriately, and getting that letter together and delivering it to the right decision maker, doing that upfront reimbursement analysis, and we'll show you a little bit of example around that. And again, dedication to preparation, 60%. So if you're drawing a pie chart of how much time to spend on these steps, this is what it ought to look like. 60% on preparation, roughly, 30% negotiation, and a very important 10% on monitoring. Monitoring doesn't have to take a great deal of time. We have some tools built into our cloud service for doing this, but not spending that 10% of time can cost you dearly because you can end up being underpaid. A SWOT analysis is basically a matrix that you fill out where you start to figure out, where are your opportunities. Could be cross-selling, collaboration, strategic alliances. We talked about relationships with employer groups may be an opportunity. Weaknesses might have to do with competition and or pricing. If you do have any functional weaknesses, you need to recognize that. You want to go into this with your heads up. Threats, competitors, closed networks, those sorts of things. Strengths, your position in the market. Do you have something unique, a unique product/service, that sort of thing? And then you put together this impactful proposal letter. Let's take a look at how that looks in a moment. And then as you get into the negotiation process, you follow up, you make sure that you iterate this, and you look for various language constructs, and then you monitor, make sure that you're being paid accurately, and then there comes a time where you're going to have to renegotiate. Some agreements are what we call evergreen, and they renew once a year, and you'll need to go back to the table once a year. Others might be locked in for a 3-year period with certain escalation factors built in. So we talk about this step of monitoring. The idea of monitoring is you compare the amount of revenue that you're getting on claims against the volume of claims that are being filed. You can do this even through a sampling technique. And really what should happen is when you multiply the volume, in this case it's reflected as the primary payer volume, and you multiply it by the primary payer rate or the contracted rate, and you compare that to the rate that is supposed to be paid on the claim, see, these two should be the same. Make sure I'm highlighting that. See this rate here and this rate here. Got that right? They ought to be the same, and therefore the delta in revenue based on the volume should be 0 because you're multiplying 0 against. Basically, you're multiplying the same number against the volume times the primary payer rate compared to the volume times the comparison rate is going to be equal. When you subtract them, it's 0. But if you subtract them, it's negative. And the problem is that means that you're basically not getting as much as you should be on your claims, and those are the ones that you have to look out for, and that's why this monitoring step is so critical. Okay. Now, language. Contracts have lots of language gotchas, and not here to take the place of your attorney. I couldn't do that if I wanted to because I'm not an attorney. But what I do see a lot of are payer contracts and operational language that affects the way you do business. And these are the kinds of things you want to look out for. Just to highlight a few of them, determined termination. You don't want to find yourself in a situation where you're locked into perpetuity and payer makes a material or non-material change and you're stuck with it. So we'd like to see a 90 days without cause. Also, the time to submit claims and get paid for claims are very critical. We talked about the lesser of language. You get paid a lesser bill charge, contractor rate, those sorts of things. Obviously, also have your legal counsel review contracts for any legal concerns, but gave you a little list here of some of the more common operational elements that you're likely to see in almost any payer contracts. So this all boils down to preparation, negotiation, monitoring your claims, and then taking note of the date that you're going to renegotiate when you start to have a large number of these contracts in place. If you're building out a map for yourself, this is critical because if you don't do this, then a contract can renew in an unfavorable way, or you get into potential inflationary period and you're not getting cost of living increases, things like that. So you really need to have a constant pulse on when to renegotiate, and during the time of the contract period, you want to be doing this monitoring, which unfortunately doesn't frequently happen. So why is all this important that we've talked about today? Because you want to find a way to gain an edge over your competition. Competition and you are both selling through exactly the same channels in exactly the same way with similar products. You don't have much differentiation. And besides product differentiation and service differentiation, you can have channel differentiation or sales differentiation, tentacles that reach out to help you acquire customers. And that's what we're about focusing on here today. It's about maximizing your return on investment, and it's about enabling your patients ultimately to get the lowest cost options for your products at the same time to enhance the treatment value by deploying your products out. And ultimately, it's to make more money while doing all of this. So the bottom line is choose your best methods of distribution, and it's not a mutually exclusive deal. Think about, are you selling to patients? Are you selling to providers? Are you selling to both? And then what are the appropriate channels, as we've talked about today, where you can best reach the patients and or providers that you're selling to. And don't limit your opportunities for growth by constraining or constricting the channels that you use. And if you need some help, reach out and call us for help. And in that regard, I really encourage you as soon as possible to either pick up the phone, call my colleague Susan Charkin, and she'll set up a time, spend a half hour with you, no cost, no obligation, talk about your business, talk about where you're headed, talk about the different techniques such as the GPOs and the payer contracts and the formularies and the PBMs and so forth, and really help you get a handle based on your precise needs about what the right map for you would be. And you can put together some of the information listed here, and she'll be very glad to handle this with you. Now, we have about 2 minutes to go. I'm going to make one final pause, Regina, and ask you if anything else at this time came in through info@HealthSense. Apparently not. Okay. So, any other questions from the audience? Just press *6. This will be a final opportunity to ask a live question if there are any. Okay. And with that, I will leave you with, you can contact any of us by reaching out to Charkin at HealthSense or Selbst at HealthSense. You can get your copies, talked about that up front, by going to www.healthsense.com/copy. This webinar will be out there in about 24 hours, but the copies of the slides are already there, and the copies of a similar prior webinar are already there if you want to grab them this afternoon, or you can wait in the next 24 hours and grab this recording as well. And that brings us to the end of our 1-hour session, and I want to thank you all for your participation. This concludes today's session. Thank you.